Ashley.
Ashley. I will remember. You look like someone I know named Anne, and so I really want to call you Anne. If I do, it's a compliment, though.
Well, that's okay. I won't correct you. I'll let you go.
You just let me know when you're ready. Ready? Okay. Well, welcome to Headache School, you guys. Thank you for coming today. My name is Carly Pippitt. I'm a family physician, so I see patients in primary care in addition to seeing patients here in the headache clinic at the university. What I want to talk to you guys about today is how do you make the most of a primary care visit when you're talking about headache. Not everyone has access to a headache specialist, and most of us hopefully access our primary care more frequently than you do a specialist, so it's important that you figure out how to navigate that relationship. Please, as I go along, feel free to ask me questions. Let's make this as interactive as possible. The first thing I would say about going to your primary care provider, and this is applicable also to seeing a specialist, is really making sure that you understand your headache history. So we'll talk about a couple of different of the histories of headache. So one is your family history. Pretty common for migraines to run within family members. So know who else in your family has headaches, what type of headaches do they have, what sort of symptoms do they have. Know your own headaches. So most of us with migraines have more, or most of us with headache have more than one type of headache. So think about what are the symptoms that you have with each of those headaches. So try to organize them around like, well, I have these one headaches that really have a lot of pressure right here, and that's this type of headache. I have this other sort of like low level kind of squeezing headache here on the sides, or I have these other really bad headaches that are just on this side that have a lot of pain. I think in a time-limited setting of primary care, sometimes we don't do as good of a job asking about all those different headache types, and to me that's actually really important, and one of the luxuries I've learned of having more time in the specialist office is I do a better job at taking the history because I have more time to do it, and I think with that extra time I actually take better care of people because I get a more complete story. So the more you can have your head sort of wrapped around, I shouldn't say your head, but the more you can have like your thoughts put together about what are my different types of headaches and what's happening with them. Knowing the history of those, like, so for women especially sometimes, well, it didn't really start until I started having my periods, or when I got pregnant it got better or worse. So kind of knowing what's changed throughout your life and how that's affected your headaches. Knowing about the medications you've used, so not only their names, but in as much as you can, the doses and how long you were on them. And obviously what happened or not. Unfortunately, if you guys have headaches, you're experienced enough to know there is not one single medication that you're going to take that's like, oh, it made my headaches, go away for forever. So concentrate on just sort of small changes that can happen, like, oh, I took that and I maybe noticed that my headaches were less intense. Like it didn't change the frequency at all, but changed the intensity of them. So pay attention to little things like that maybe don't seem like a big deal to you, but I would tell you are pretty important that way. And then, especially when you go into your primary care provider, make sure that you, just like with your headache specialist, bring a diary. That is so helpful, and I know they're kind of a pain in the neck to do, but is really great information for us. It would be really great if you had at least a month, probably 3 months is better, and do this in whatever way works for you. I can't tell you that I have seen a headache diary that I was like, that is not how I want the information. However is easiest for you to do it. I know a lot of people like the My Migraine Buddy. I think my favorite one I've had a patient do is, those like big desk calendars that used to take up the whole thing. That's what she would do. So she'd like unfold this gigantic piece of paper and we'd look at it together, but it was easiest for her because she could write everything down. I'm a pretty visual person too, so that was the easiest for me because I'm like, oh, like look at this, we've got all these days in a row, as opposed to sometimes scrolling through something. But do what works for you. I think most important with your primary care is, just like with any other chronic condition that you have, if you had high blood pressure or you had diabetes, this is something that warrants its own visit. And I talk to my colleagues in primary care about this all the time. Like the joke I'll often say is, you came in for your diabetes and your hypertension, and oh, by the way, you needed refills of your headache medicine. But we never really give it the time that it deserves to really have a conversation about it. And I think sometimes from the primary care standpoint, there's no numerical measures of like, well, your blood pressure was this, or like your diabetes control was this. I mean, you could argue like, well, I went from 10 migraine days to 2 migraine days, but I think sometimes that's not quite as satisfying because it's still just based on your report. It's not based on some lab of how good are your headaches controlled or how are things going that way. So I think sometimes if your primary care doesn't advocate for it being a single visit to discuss it, make sure you advocate for it because you want to make sure you use the time wisely that you have with them. And then when you're talking about your medications, think about how you're using them. So when we talk about medications, we'll talk about sort of the 2 broad categories. So prevention, things that you take every day to try to prevent migraine, and then ones that you use for rescue or only when you have migraine. It's not uncommon that you might be taking your rescue medicine every day. So just be thoughtful about your intention of what you're taking it for. I've seen a lot of people who are taking medicines that they may say, oh, I take this every day for my migraine, and think they're actually doing it for prevention when they're not. Actually, it's probably a rescue medicine that they're using too much. And that's a bit of a dig on us as providers as well, making sure that we're really clarifying what are we giving you and what are the goals with what we're giving you. What are we really trying to accomplish that way? What questions do you guys have? I have a couple other thoughts, but I feel like I've just talked quite a bit at you, and I'd rather hear some of your thoughts about this. Who do you guys see for your headache? Is it mostly your primary care provider or is it a headache specialist?
So I have a surgeon that I had on my eye, so I go to him every once in a while. But other than that, just my primary care person.
Good, good.
Yeah. I think it's hard for me because I'm the mom, so I'm trying to explain to the doctor what she's explaining to me. So I don't think I always have all the information. And then I also feel like a headache is such a broad thing. I don't know how to stress how debilitating it is.
Yeah,
to
absolutely.
them. So I think they're asking all these random questions. So sometimes I think we feel like we're not getting the answers we want.
Yeah.
Because there's not like one.
Yeah. I think you bring up a really good point that headache is in general such a broad thing that it's hard to. It feels like you're narrowing it down too much. So knowing that your different types of headaches and knowing that history, that's one reason why I think that's really important to help give your primary care provider a bigger picture, sort of that like 30,000-foot view of, hey, this is actually all the different ways that I have headaches. And then I think helping them understand these are all the different ways that my headaches affect my life. Because although we talked about that, maybe headaches aren't as sexy or exciting or rewarding as some of those things, what we do know is they cost society a lot of money, right? Like you might not be able to go to work or you might not be able to go to school if you have a headache because your symptoms are really so bad. That then in turn costs money. I mean, it really does have a pretty big financial impact that I think is not always the first thing you think about, but it really is an important thing that does affect so many different issues. What do you think you could do to help empower you, Ashley, to sort of give that history in an impactful way to your primary care?
I could probably just think about it more, maybe try to determine what is happening.
I think we talk about a log, but sometimes you just get busy and
absolutely.
Then your headache is, and then going back and thinking about it. But one thing I was going to ask, so is it better to find an actual headache specialist than go to your primary care physician?
I think that's a really great question. So is it better to find a headache specialist or to find someone in primary care? You're going to get a little bit of a biased answer since I live in both worlds. I would tell you that I think migraines are a primary care diagnosis, and this is really something that we should be treating. I think, unfortunately, because it isn't very rewarding to some people, it does sometimes get pushed into the realm of specialists, and I often tease that one of our problems here in the headache clinic is people get better, right? Like they haven't had an answer. They've been talking about this to their primary care for however long, and they don't feel like they ever made any improvement. And so when you finally go to someone who makes you better, you never want to leave that person because this is finally the person that you feel like maybe listened to you and finally pushed things in a direction that made stuff happen. So you sort of never want to let that go. but I don't think it should have to be that way. I try pretty hard when I see people to say, you know, these are our plans. This is my plan A, this is my plan B, this is my plan C, this is my plan D. So if these things don't work, you're more likely to get into your primary care before you're likely to see me again. They can implement these plans next to try to help empower the primary care that they feel like they can take the next steps so that they can do that. I think it's going to be a partnership in some way, shape, or form. And I think to try to get people the best care that they can, it should be a partnership between you, your primary care provider, and your headache specialist, all working together to make your care the best it can be. I don't know if that was a great answer, but hi, welcome you guys. Thanks for coming. So I'm a primary care provider. My name's Carly Pippitt. I'm a family physician, and then I also see patients here in the headache clinic. So we've just been talking about how do you make the most of your time with a primary care provider in sort of a time-limited setting to try to talk the most about headache and get your best care. Do you guys have any questions? Now that I just put you on the spot, just like that.
I'm so lucky because I feel like I have a really good doctor that is my primary care doctor and also my headache doctor.
Excellent. So it works out well if you happen to find that perfect balance of someone who's interested versus not. I think one of the hard things about primary care is there's a lot of things that we have to know about, and for each of us there are things you're going to find more interesting than others. But I would say that still doesn't mean that even if you have a primary care provider who isn't necessarily interested specifically in headaches, they still should be able to take good care of you and manage your headaches appropriately. That, you know, they may get to a point, just like with anything, like with, you know, the kidneys or something, or like the stomach, I might be like, okay, I've reached sort of the limits of my knowledge, now let's send you to a specialist to sort of work together to take care of you best. I mean, like I said, in theory, you would think that you would see your primary care provider a little bit more frequently for other issues, and then that's something they can check in on at other visits for your chronic conditions. But you might just see your headache specialist just a couple times a year, if that, depending on how well controlled things are. And it might be that you see, if you get to the point where you need a headache specialist, you might see them a couple times up front and then sort of back off, see where things are at, and kind of engage primary care in that way. But with anything, figuring out who's your team around you to get you that best care possible.
I guess, what is the difference between a headache specialist and a primary care physician? I mean, what are,
Yeah, that's a really good question. So what is, I'm repeating your questions just for the video.
That's okay.
So like, you know, I did actually hear you. So what is the difference between a primary care provider and a headache specialist? So most headache specialists are probably neurologists. So they've gone through, you know, we've gone to medical school, and then you go to your sort of specialty training from there. Most of them have gone through neurology training and then a fellowship from there, whereas primary care would either be internal medicine, pediatrics, family medicine. Some people would consider OBGYN to be a primary care provider. So they do sort of that residency training and then are focused on sort of diseases and disorders within that specialty in particular. So a neurologist is going to spend a lot more time managing people with stroke or multiple sclerosis, whereas a primary care, I'm also going to learn how to take care of kids and deliver babies and take care of blood pressure and do all of those sort of different things. So they may, who gets more training about headache just in your sort of general training? We probably both get a little bit of it. Maybe neurology gets a little bit more, but you could argue of all the different things that come into a neurology clinic, not all of them are headache. There's probably a handful that are headache. There's probably a handful of headache that comes through primary care as well. Some people will do a fellowship to get more specific training in headache. You can do that from any specialty. You don't have to be primary care. You could be neurology or some other specialty care. And I think some of us have fallen into it sort of accidentally because we had a personal or professional interest, and that's why it's sort of come from there, and then have either gone for extra training to figure out how to be better at it or engaged with a team that can help you figure out how to take better care of patients. Does that help answer that?
Yeah, thank you.
Other questions? Welcome.
Thanks.
So we're just talking about how to make the most out of your primary care visit when you're talking about headache.
What did you share your background, your prescription that you're taking for your headache? Did you guys talk about that?
We talked about, so the question was about what are the prescriptions that you're sharing, that you're taking for your headache? How do you share that with your primary care provider? So one of the things we talked about in general is making sure you know the different types of headache that you have. So coming in to your doctor, specialist or not, and letting them know. So, you know, I think I have a couple different types of headaches. I like to think about people explaining them more about the symptoms that they have, like, oh, I have these one headaches that have a lot of pressure right here, and then I have these other headaches that feel like there's a vice, you know, on my temples squeezing my brain, like I feel like it's gonna pop out. I like people describing the symptoms to me, because to me that's more helpful, and it helps me think more. Sometimes when people throw out the term migraine, or throw out like sinus headache, or throw out kind of what they think of a diagnosis, it might narrow someone's thinking too much that I'm not thinking more broadly about what else this could be. We know that a lot of sinus headache is migraine, and people just think it's sinus headache because it's associated with pressure. So to help your provider not narrow down their sort of diagnostic possibilities too soon, if you can kind of speak in more generalities or symptoms about what's going on, that might be more helpful. And then talking about being able to know what are the medicines you've taken in the past, not only their dose, but the duration of time that you took them. So, and did you have any benefit at all? And it might not be, we were teasing earlier that there unfortunately is no medicine that's going to get rid of your migraines magically and you will never have one again. But was there a medicine that maybe didn't change how often you had your migraines, but did maybe make them, instead of a level 8, they were like a level 6. So that was a little bit more tolerable that way. And then keeping in mind what you took medicines for. So did you take them every day to try to prevent migraines, or did you take them just when you had migraines? So what were you told to take it for, or how were you taking it? So that it's just sort of helpful information moving forward for everyone, to make sure that we were saying sometimes we may give you a medicine that's really only supposed to be taken when you do have a migraine, and there may not be good explanation about that, and then you inadvertently are taking it every day, and that might be making things worse. So understanding why you're taking it. Does that help answer that a little bit? Mm-hmm.
So it's better to say it hurts right here, or it hurts right here, rather than say it's a sinus.
I think so. And we were saying, you know, sometimes you might say, well, so I've got these really bad ones that, you know, feel like there's this, you know, like my head is like, there's a bubble in my head that's going to pop, like there's this pressure on the inside. But then, you know, every day I've kind of got this like low level here at the back of my neck that goes down a little bit that way. Yeah, I think sometimes in that time limited setting of primary care, we don't always do a good job of saying, well, do you have another headache type besides that, or is that the only one? So the better you know about all your different headache types, the more complete of a picture your care provider gets, and can figure out how to tailor your treatment that's going to make the most sense for you. And know too, okay, so maybe I have this everyday headache in the back of my head, but that's not really the one that bothers me. The one that bothers me are the like, oh, when I have this really bad pressure right here, that one is so hard for me because I can't walk outside, the bright lights really bother me. That's the one that's the most frustrating to me. So be prepared if you give sort of this, you know, menu of, I have these 5 different headache types, but these are the ones that really are affecting my life the most, then that's what you'll be able to focus on. Because if you tell me you've got 5 different headache types, I might be thinking about treatment for one of them, but that might not be the one that's bothering you. I mean, and that could be the case with anything you go to the doctor with. I want you to know my toe hurts, but I don't want you to do anything about it. I just want you to know. Mm-hmm.
Yeah, because I had all those like through here, and then it turned out I really did have a sinus infection.
Mm-hmm. Yeah. So just making sure you give as much of the whole history as you can. What else is going on? You know, did you have a runny nose? Did you have a fever? Did you have a congestion? Just what are your other symptoms to go with it? Yeah. But all of that is going to be helpful to your provider so that they can make sure they make.
I had to go to a sinus doctor for primary care.
Mm-hmm. I think sometimes too, when you're a specialist and that's all you see, it can be easier for you to make a diagnosis, but it can also put blinders on you, right? Because if you're a sinus surgeon, then all you see is sinuses all day. So, you know, you're sort of anticipating a sinus problem from the get-go, when if there was a more full history, you know, and maybe whatever they did with your sinuses didn't make it better. You sort of went down this whole path for your sinuses when that may or may not have actually been the original issue, if it was a different case. I mean, it sounds like it was in your case, but. Other questions? Yeah.
How many of the providers would you say, percentage-wise are like utilizing nerve blocks, Botox, IVs, injections? Because it took me 15 years to find someone who was at that level that they could address my migraines. That's the only thing that's reined them in. It's not any type of medication at all.
Yeah, so really great question. So what percentage of providers are really doing more procedural type things, not just IV medications maybe for rescue or for treatment in clinic, but also things like nerve blocks, Botox, things like that? I would tell you probably not very many. For a couple of different reasons. One, most of us, it was not a part of our training at all. So unless it's something that you went out and sought, you probably don't know how to do it otherwise. For things like IVs, some of it depends on how your office is set up. Like you might be able to say, hey, if you have a headache, come in and we can give you IV fluids and treatment here. That might be a matter of either space, right? Do you actually have the physical space in your building to support that? In our primary care clinic, we hardly have the physical space to support the people we have there. So to ask us to put someone in for an acute treatment, like we're just not set up to handle that right now. Do you have staff that can do that, right? So here at the headache clinic, we have a nurse who has sort of a protocol to go through, who can reach out to us, but essentially has a set of orders in place to say, okay, this is where I start, you have a headache, this is where I go. Your primary care office may or may not have an RN who can do something like that. You may or may not have an agreement with them to do something like that. So IVs is kind of a different, more specific thing, but most of the blocks and things like that are a matter of training and potentially a matter of a lot of them take some, I'm trying to think about how to say this politically, like there are some things you have to do for insurance to make them happen. So again, do you have the support to make sure you're going through the correct processes so that then you can actually get reimbursed for the work that you're doing to continue to do that? The one sort of small exception I would say to that is trigger point injections. That's something that probably most of us in primary care are trained to do. That's going to be a little bit based on your specialty. In family medicine, I know that's something we do. I know OBGYNs who do it more for pelvic pain, not for head pain or anything like that, but would be someone who knows how to do that. I don't know about pediatricians and internal medicine physicians. They could, and I just don't know that necessarily. So that might be one procedure that they might be able to do a little bit. But most of us have some medications on hand, but they're more like an injection we're going to give you once, and it's not usually an IV fluid or sort of like a length of time we're going to let you kind of be there and recover, unfortunately, which I think is a really critical thing. I think not only do some primary care providers not know how to do those injections, some of them don't actually know that's an option. I think we are getting a little bit more traction in that realm now that people do know that's a possibility. Sometimes that's good and bad. We get referrals here sometimes to the headache clinic for someone to go on Botox, and they've never been on a medicine every day to try to prevent their headaches. So there's still definitely some education to be done, because you're not really a candidate for Botox unless you've done a bunch of meds and have a certain amount of headaches. Right. So we're getting there. It's not great, but we are getting there. Good question.
Yeah, so what are trigger point injections? They're for migraine?
Trigger point injections could be for migraine. Sometimes we think about them more for something we call myofascial pain, which might be related more with sort of a tension headache. But sort of that tension could lower your threshold that you might have migraines more frequently. The best way I had someone explain it to me was, so I think we all would say we understand the experience of you exercised a lot and your muscles were really sore, right? That kind of soreness you get after you've, I don't know, held a position too long, or you've exercised or used muscles or something like that. This is a different type of muscle pain where there's like fibrous bands within there that just get sort of taut. And And there are different ways that you can use to sort of relax this. Most of us could, push somewhere on our shoulders and say, oh yeah, I'm sort of sore right there. Like that feels good when you walk behind me. Places that are really great for trigger points. Some people will say trigger points specifically. If you push on a place, you have to have radiation of the pain. So if I push here, it's not just that it hurts right here, it's that I push here and it actually hurts up my neck and down my shoulder, or at least sort of one of those places. And if you Googled like trigger points, that you can see maps where they're like, oh, there are these trigger points here, and if you push on one of them, these are all the different places it will radiate. And I have yet to show someone, like maybe I can't find it. I can find them on myself pretty easily. I can't always find them on other people. But if you show one of those maps, if you look at it, people will be like, oh yeah, I've had that happen. I can push it there. And the thought is there's a couple different ways to kind of break up that. Trigger point injections is one option. It's not the only one. Massage is something that can help. You could do, we'll usually talk to people about something like a Theracane. So it's like a green, do you guys all know what I'm talking about if I say the Theracane? So it's like this green sort of plastic tool that kind of looks like a shepherd's hook and has like little balls on it that you're kind of pushing into those. So that's a way you can kind of break it up. We try to teach people different ways because you need to be able to break them up on your own. Some other sort of tricks you could do are take like a lacrosse ball or a tennis ball and put it in a sock and put it behind you and go up against the wall, something like that. Those are all things that can help. Some physical therapists will do things with it too. There's nothing special about the medicine that's injected in a trigger point injection. Typically we'll use a local anesthetic, something like lidocaine or bupivacaine, the same medicine you use when you get the dental work or things like that, or a similar medication. Physical therapists will actually do something just called dry needling, where they're not putting any medication at all. They'll just put needles in those trigger points, and that can be effective for some people. So I mean, that's another realm where we're seeing more people get educated in these techniques so that there are potentially more venues for therapy now that we didn't have before. Mm-hmm. Great questions, you guys. Yeah?
Do you see many primary care physicians seeking out this type of information? Or do you find that it's people who are experiencing this sharing it with them?
Yeah, so the question is, are there a lot of primary care physicians seeking out sort of extra information about headache in general? It kind of depends, is what I would say. We were teasing a little bit earlier that headache is unfortunately not a very sexy diagnosis, right? There's not a like, hey, we got your blood pressure to 115 over 75, or your diabetes control is 6.2. Like there's not. Even if you said I went down from 20 migraine days a month down to 2, sometimes that's just somehow not as satisfying. I think it's really satisfying, but yeah, I think it is too. Maybe not for everyone. I think some of it too is it's a really incremental, slow change, and I think that can be really hard for patients and providers alike. It's something you have to be very patient and very slow with. I think most of us in primary care are a little bit more accustomed to that than like a surgeon who's like, oh, you have pain in your stomach, your appendix is inflamed, let's take it out and now you're better. I think we're pretty used to, it's not like a one and done sort of thing. But because there's so many things we have to know, I think it's not very common that you're gonna see, you won't see too many people go just to a headache conference to get more information on that. You might see them go to some sort of adult, what are hot topics in adult care or something like that, and then hopefully something like this will come up. So not as many as I would like. I think some of it depends on what did you see in your training, did you have difficult cases, who were people around you who were sort of interested in it. In my primary care clinic for a while, people would send patients to me, and I've actually told everyone I'm not going to see their patients anymore, but I will look at their charts and I will give them ideas and I will help them with patients, because it doesn't do them any good to send all their patients to me. Like, we're not improving care or training more doctors to be better at caring for this if they don't actually care for it themselves. Because I think you have to see, okay, we tried this, I'm going to see you back in a month, where are we at? Just like any other thing you do with a medicine. So sort of taking that time to go through and be patient with the slow change and setting up that expectation for both of us, right? If you come in and you tell me that you had a migraine every single day for the last 5 years, we're not going to make that better in a month. We're probably not going to make that, we're not going to make a huge dramatic change on it. But if we could fast forward 5 years, we might actually see that we've made a difference. It's just been really slow and progressive. So having that patience, which sometimes we all have, sometimes we don't have quite as much when you're miserable and you want to feel better sooner. Great question.
So do you prescribe medication over like the occupational therapy or the physical therapy?
Oh, for different headaches or things? Yeah.
Mm-hmm.
So the question is, what would be my preference in terms of like medication versus physical therapy for treatment of headaches or migraines? It depends. So very much depends on your history, what types of headaches that you have, what do I find on physical exam, what other medicines have you tried before? It depends. That's not a very satisfying answer, but sometimes my colleagues will ask me, when we're thinking about prevention medicines for migraine, they'll say like, okay, so what's your algorithm? Like, where do you start? Where do you go to next? Like, what's your sort of like, this is my top choice, this is my next choice, and this is my next one. And even that to me is not that easy, because we might have a conversation and I might pick one medication for you, and you might give me a pretty similar history, and I might pick a totally different medicine for you, just because it's more about your history. What have you tried? To me, it's not just an algorithm simple answer. It's taking into context all of your headache history, all the different headache types. What are other lifestyle things for you that are going on that may or may not make a difference? So it kind of depends on what else you've tried and what else is going on. For some people too, it depends on your interest. Some people don't want to take medications if they don't have to. So I will think more differently that way if that's your choice. Some people don't have time. Like physical therapy takes time and takes some work to get there. So if it's not an easy thing for you to do, it might be sort of our like, well, this is our plan B if this medicine doesn't work, or this is our plan C if this medicine doesn't work. So kind of in that list that way. Mm-hmm. Yeah.
I have a question. Would you or do you ever prescribe narcotics?
Yeah, so the question is, would I or have I ever prescribed narcotics?
For headache or concussion.
Yeah, for headache or concussion. So for concussion, I'm definitely less likely to, kind of a different thing, because there's usually some concerns about how you're thinking. So I really try to not give you things that affect the way you're thinking. Can I tell you that I have never given people narcotics for headaches? No, I can't say that. There are people in the past I have. If I was telling you in an ideal world, would I do it? The answer is no. And really the issue is we know that the more frequently you take narcotics for your migraines, you're more likely to get into a chronic migraine. There are plenty of things we do in medicine, unfortunately, that actually make you worse in the long run. This is one where I think, unfortunately, we've done that to people. Not because we were trying to make you worse, but because that was information we didn't have and we didn't know. And sometimes if you've tried a bunch of medicines and you're desperate and your primary care provider is desperate, that might be the direction that you go. And then we get you into a situation where that's not the right thing to do, but it was not out of any ill intent from the beginning, is what I would say.
Is that well known enough now in the medical profession?
So is that well known enough now? I think it's better known. I think there is probably, you guys have probably seen, there's a lot more press about opioids now and limiting use of them. So even if there's not as much knowledge or awareness of it not being the right choice for migraines, I think there's enough knowledge and awareness that it really shouldn't be used long-term for any condition if you can help it, or really should be used in the most minimal way possible. That's probably going to have more of an impact than specific information about migraine or headache in general. Mm-hmm.
Since concussion makes migraines, concussions are definitely not good for a person with migraines. Mm-hmm. And I have a concussion, what is the proper way to treat a concussion?
So your question is, concussions and migraines unfortunately play a little bit too well together, mm-hmm. and so what's the best way to treat a concussion?
When you get a concussion, what would have been the best way
mm-hmm.
to treat it?
What might have been the best thing to do?
Yeah.
So what we'll usually talk about if you have a concussion is...
I was knocked out cold skiing.
Oh, goodness, yeah. So if you get a concussion, one of the things we always talk about, and you'll see this in athletics, because they don't let the athletes play, right? If you have a concussion, they actually keep them out. So that's one of the first things I would say is we usually tell people you should have brain rest. So you really should try to be good to yourself and not do things that are very taxing to your brain. That can feel kind of silly because things like reading, things like watching TV, those are actually cognitive tasks that you're asking your brain to process information. Those can make migraines or even just headaches following a concussion worse. So really trying to do things where you're resting. Physical activity can be another trigger for some people. What I'll usually tell people is you should, if you do something and you have symptoms, you should sort of take a step back. So like if you're walking and you do fine and maybe you want to go back to jogging and you try that for a day and you do it and it's bad, okay, well then you just go back to walking from there. I think most people just get really frustrated because you're like, I can't really do anything. And that is kind of the problem. You just have to sort of gradually increase what you're able to do. I find that people with migraine sometimes tend to have more issues with a concussion afterwards in terms of like pain or headache or things like that. We'll often describe the migraine brain as an irritable brain, meaning that like something that bothers you, like a concussion, right, might really affect you, doesn't affect other people in the same way. And that's kind of the analogy I would use for this too. Everything just can sometimes get dialed up to this like 11, right? Like your brain is so loud, everything is at an 11. And so it's the same idea with people with migraines. You're just trying to settle things down. So usually using some sort of prevention agent, often like an anti-seizure medicine or something, to try to calm down that level of irritability so that those little everyday activities that you used to do, things like walking, running, watching TV, reading, doing your job, all of those things don't sort of trigger you that way. The sooner you can get in, the better, because just like a chronic migraine, the longer those things are established, the more time it takes to turn it around on the back end.
Yeah, so like 30 years later, probably.
30 years later might be a little bit harder to break that way. And I think sometimes there needs to be a conversation about, we may never make you pain-free, but how can we at least make you more functional with what you're doing? And I don't really like to be that bearer of bad news, but I think being honest with people about what are your expectations, just like we tease there is no medicine that's going to get rid of migraines for forever. You know, if you've had pain every day of your life for 30 years, there's probably nothing I'm going to do that's going to make you better. But what could we do to make you more functional? So just kind of reframing the conversation that way, not to be the doomsday nay speaker, but naysayer.
I just have one more question. Can head trauma like that, and this is probably the chicken before the egg before the chicken, can head trauma like that be a cause for fibromyalgia, or does fibromyalgia, you know, like one of those autoimmune diseases that you don't know which one came first?
Yeah. So the question is about, could head trauma be somehow sort of a cause for fibromyalgia, or could fibromyalgia sort of make things worse? I think we really don't know. And I think that's one of the really frustrating things about, for as much as we don't know about migraine, there are a lot of other diagnoses that we know even less about, things like fibromyalgia, chronic fatigue. So what I'll often tell patients, I just try to be really honest. Like, we don't really know. Like, there is no objective lab test for these things. We don't really know what causes it. We have some idea of how to treat it, but we don't necessarily know what might cause a flare in you that doesn't cause a flare in someone else. So unfortunately, sometimes we just have to treat the symptoms. And I think even in headaches for some people, that can be really frustrating, that sometimes people really want to know the cause. We unfortunately don't know the cause in a lot of things in medicine. And as I'll tell patients, as you become more engaged in the medical world, either as a provider or as a patient, you learn that there's really actually a lot that we don't know. And so unfortunately, we are left with treating the symptoms because that's what we know how to do, and that's what we have medicines to do. And I think for all of us, you feel like you're doing something, because I think it's really frustrating to just be like, I don't know what's wrong with you. Sorry, you're just kind of hosed. See you later. Like, I don't have an answer for you. So just trying to be honest about, I don't know, but these are things we might be able to do. Any other questions? Awesome. Well, I hope you guys all go on to have a really fabulous relationship, not only with your headache specialist, but also with your primary care provider. I think many people with headaches end up educating your primary care provider a lot about headaches, just because you guys are usually really great patients who are really open, transparent, and really willing to talk about things and try stuff and keep moving forward. So please keep that up. You're helping train the next doctors too. Okay, thanks guys. My pleasure.